We're going to have to borrow a slide to kind of put some actual hands-on perspective to it. And of course, we attribute this to Dr. Sizer, who's, and this is the old version. Of course, Phil's got a new version, which is a little more slick, I think, and a little bit more specific. But for our purposes, I just want to make sure that we understand kind of where we're going and how we got here. Of course, if somebody comes to us because there's pain, which is the most recent, people, it may be that somebody with temporomandibular disorder or joint pain comes to us because they have a clicking or something, but more likely it's pain that really gets people to see us. That requires a medical screen, and the medical screen attempts and will, in many cases, try to acquire a structural diagnosis. And I suspect you've already experienced this in the other modules. Now, we can't just leave a structural diagnosis in place with a clinical exam. We also have to do some functional testing and functional examination so that we have a more complete understanding. However, the IAOM approach has been consistently a systematic approach towards addressing the pain generator, the motion segment, and that's done with specific diagnosis-specific techniques such as manual therapy and the skills that you've learned in many other courses. Now, we can't just mobilize a joint, and you'll hear Phil and Brent Denny talk about this. You can get something moving, you can improve the motion segment, the mobility of it, but we really also have to teach the patient how to control that. Not necessarily just rely upon the old motor systems to kind of re-engage, but rather sometimes we have to jumpstart and employ some new strategies, some new motor programs, and that's done through psychomotor and somatosensory control. Fundamental activation, diagnosis inclusive, and that's kind of this whole seminal course series, which is absolutely worthy of your attention because you'll have a systematic approach to understanding which exercises and when. And then ultimately, as the patient continues to improve, we need to move them towards fundamental performance, advanced performance, and functional advancement. On occasion, patients will come to us with a functional problem, maybe perhaps not in the temporomandibular joint, but perhaps. We could start with a functional examination and then realize that there may be some structural component, but it's going to lead us to the same place. So to get us to a proper design, a proper treatment plan design, we have to start with a structural diagnosis. We also have to conduct a functional diagnosis. In other words, both exams lead us to a diagnostic paradigm where the tissue is the issue and the function is the issue, and then formulate a story. But we can't stop there, and Phil did a good job of putting this in here, and this slide's quite old. There's a biopsychosocial assessment, although we're not going to use the process of assessment because you're going to have your own kind of an internal assessment, but I don't want to confuse that with this idea that we're creating in any way, shape, or form a psychosocial diagnosis. It really isn't what we're trying to accomplish here. We're instead trying to develop an appreciation for how important it is to have an underlying understanding of the biopsychosocial contributors to the patient's experience. And then from that, as you can see towards the bottom, is we can have a biopsychosocial interpersonal management process. In other words, we can engage the patient in a way that enhances the chances of success because we're engaging with that part of their nervous system, the interpersonal part, the parts of their nervous system that help them to regulate the physiological state that is going to be best born, best accomplished, best established to help you with the other modality and procedural based treatment that you're going to employ.